Hi everybody, welcome to this webinar about global perspectives, evolution of treatment and managing adverse events. I want to thank in name of all the speakers to Total Health Advancing Care Through Education for this support. And here you can see the expert panel. We are going to share this webinar with Dr. Jeff Lipton, from the hematologist from the University of Toronto, Canada, and also with Dr. Hemant Malhotra, from the hematologist from Sri Ram Cancer and Superspeciality Center in India. I'm Dr. Carolina Pavlovsly. I am a hematologist, head of the research department in Fundaleu Center, Buenos Aires, Argentina. And we are going to talk about the basic now management of CML. The principal objectives of CML are to obtain an optimal response in time. And it's very important the personalized treatment and how to select the treatment in the patient at diagnosis. So one of the options is to think about what we want when we select the TKI. Optimal evolution, a prolonged survival with TKI, maintaining quality of life, and prevent also the patient to accelerate phase or plus crisis. Here we can think on, for example, Imatinib. And also we have a second generation TKI in first-line possibility, where perhaps the objective is to obtain a sustained and deep molecular response with the objective of discontinuation treatment and a long-term survival without TKI. So the baseline work when you are in front of a recently diagnosed patient is, as ELN recommends, to make a physical examination, complete blood counts, the bone marrow aspiration, that's very important with the cytogenetics and the core biopsy. Importantly also, and it's what's going to define the diagnosis, the chromosome binding analysis. And if this is negative, the FISH, only in cases of Phi negative. It's very important to identify the transcript type and make a qualitative reverse transcript polymerase chain reaction, the famous PCR, for detection of the transcript. Also an ECG and the standard biochemical profile with hepatitis serology. The second point to follow our patient is how to monitor the patient. And this is a very busy table, but what's important to take into account here is the third column about failure, because it's the one we are going to consider when we change treatment. So the ELN has published recently this, and what is interesting is to see for example, at 3 months we can see that patients that have more than 10% of BCR-ABL are in failure, but they have to be confirmed within 1 to 3 months. This has to be repeated. At 6 months, the confirmation of more than 10% is a failure, and also more than 1% at 12 months. Anytime, if the patient has more than 1% of BCR-ABL or the appearance of mutations or high-risk abnormal cytogenetics, we are considering a failure. But sometimes we cannot follow all this in the real world. That's why it's important to take into account some points that have been published about perhaps the important things the real world is perceiving. For example, lack of treatment options in newly diagnosed patients. What is important here is that second-generation TKI must be considered as first-line treatment, especially in high-risk disease. Another important thing is that non-continuous treatment are due to compliance, toxicity, and non-availability, and this is very common. Also, it's common the lack of access to continuous monitoring and also monitoring in non-standardized labs. So we have to go through monitoring in standardized labs. Also, branded versus non-branded quality TKI is in the few years ago a very important thing that is debating, and that we must show, and we're going to show in future slides about this also. Lack of access of mutational tests and lack of access to allogeneic stem cells transplant is also some of the issues in the real world. About the requirements on TFR, and this is very important because we must discontinue just if we have patients that can have the objective of having the points that I am sharing here in the slide, and they fulfill all the bullets. For example, the ELN says that these are the requirements, and that some are mandatory, some are minimal, and some are optimal. The mandatory points that the ELN says that it's very important if a patient is going to discontinue are, for example, that the patient must be in chronic phase only, and this has to be a very motivated patient with a straight communication. This is really very, very important, and the patient must know that the quality, the PCR has to have a very high quality PCR with a very rapid turnaround test. The test must be, for example, the results must be given in 15 days, not in 1.5 months. And the patient must agree to have more frequently monitoring after stopping. Perhaps in the first 6 months, the patient must be in the hospital every month, and this is a very important issue because the patients are not prepared to affronting this, and this is a point that we must say to the patients. Also, every 2 months, from month 6 to 12, and every 3 months thereafter. Some minimal requirements are, for example, as typical transcript, the duration of TKI more than 5 years, and the deep molecular response obtained. They defined as 4.5 during more than 2 years are one of the minimal requirements. So this we have to take it into account to consider if we are going to interrupt treatment. One of the first and huge trials, this is an example because there are a lot of trials of discontinuation, is the EUROSKI trial that included 758 patients, and there were patients that had TKI treatment more or 3 years. The molecular response they used was 4.5 for more than 1 year, and the definition of relapse was the consideration of loss of major molecular response, that is 0.1% of BCR-ABL. And as you can see in the curve, at 36 months, we can see that the molecular recurrence-free survival was 47%. So this curve is very similar to the rest of the clinical trials that have been published, and also to our region, where the first relapses are during the first 6 months, and then the patients achieve, as you can see, a line in between 40% or 50%. So as I said, it's very important to share and to follow a guideline. Wherever in the world you are, there are a lot of guidelines, NCCN, ESMO, the Leukemia Net, as you all know. And in Latin America, we are in press with an article in Blood Advances where we are publishing the LALNet, Latin American Leukemia Net Expert Panel, where we are sharing here the most important difference with other guidelines. And we consider, for example, mandatory to have the transcript type, where Leukemia Net says that's a minimal requisition. Another thing, for example, is that it's not mentioned in the Leukemia Net guidelines is about the SOCL score. We consider the high SOCL score risk patients should be informed of the possibility of a higher risk of molecular relapse. So we in Latin America need special attention to this population. Also, it's mandatory the depth of the molecular response required, and we are refining 4.5. This is a difference with another, for example, with the Leukemia Net, because they say that it's 4.5 more than 3 years, and this they consider minimal. They also share 4.5. So there are some differences, and we analyze also some psychosocial consideration and pharmacoeconomic aspects. So this is the reality for our region. Also, the Leukemia Net, and this is a point important in the failure, recommends making the mutation analysis previous to changing the treatment. So we have a patient in failure, we must make a mutation analysis, because we all know that, for example, if the patient harbors a T315I mutation, the treatment recommended is Imatinib. There you have different type of mutation and the recommended treatment to follow. In the other part of the slide, you can see the management strategy recommended for the end phases. I'm not going to read it all, but it's important to take into account that, for example, in primary blast phase, starting to Imatinib and changing to a second generation TKI according to kinase domain mutation profile is recommended. And if we have a failure in ponatinib in this population of patients of high risk, we must study, and it's recommended early, an allo transplant. Also, for progression to blast crisis, we can attempt a second chronic phase, as we all know, but the outcome with currently available TKI is poor, so we must switch to the chemotherapy and as it's recommended. So now I am going to present and move forward to the next speaker, Dr. Hemant Malhotra, that's going to talk about discussion on generics and some real-world life experiences.
Hello, everybody. Welcome to this webinar. My thanks to Total Health for organizing this. My name is Dr. Hemant Malhotra. I'm director of the Shri Ram Cancer Center and professor and head of the Department of Medical Oncology at the Mahatma Gandhi Medical College Hospital in Jaipur, in India. I'm also on the scientific board of the International Chronic Myeloid Leukemia Foundation. Real pleasure to be here. My brief today is to discuss something about generics today. So ladies and gentlemen, when we talk about generics, all generics are not of the same quality, and we are talking today of quality generics. And we'll try and consider some of these factors in the subsequent slides, setting realistic expectations, emphasizing practical ways how to do this, and of course, making sure that we monitor adverse effects and monitor milestones carefully. So, ladies and gentlemen, in low and middle income countries like my country, which forms about almost 3/4 of the world, and which houses about 3/4 of the world's chronic myeloid leukemia patients, and there are some specific problems. And just to highlight 4 important problems for you: economic issues, no medical insurance and out-of-pocket payments, long distances to the closest medical expert laboratory, too few medical experts for a huge number of patients, and too few qualified labs to deliver quality BCR-ABL and kinase domain mutations. And amongst these 4, the most important factor, remains the economic issues. This has been addressed by this beautiful write-up in the Blood, very often cited, 2013, of a group of experts from all over the world. I had the privilege to also be on this group, and this was led by Dr. Hegop Kantarijian from MD Anderson Cancer Center, and they did conclude that the price of cancer drugs, including price of CML drugs, is almost unsustainable. And even in the most developed countries of the world, people are now talking about costs. This is the NCCN, latest NCCN guidelines for you. And even now they have an evidence block, and they have an affordability of the regime, pretty importantly highlighted in the guidelines. This was the cover of Time several years back. Medical bills are killing us. So, ladies and gentlemen, world over, an effort is on to reduce costs of treatment. And one accepted way of reducing costs of treatment is the availability and the use of generic drugs. And this has been not only endorsed by the WHO, it has also been endorsed by the US FDA. And the latest ELN guidelines, European Leukemia Net guidelines, they also talk about generics, and this is what they say about generics. Generic Imatinib is cost effective as initial treatment in chronic phase chronic myeloid leukemia, and they recommend that the same generic brand should be used if possible to avoid potential side effects and the change in bioavailability. So if a patient who is well controlled or newly diagnosed is being shifted from Gleevec to a standard quality generic Imatinib, then the same generic Imatinib should be continued, and several generics should not be used in the same patient. Now, ladies and gentlemen, the quality of generic has always been a question mark, and I'd like to just show you one little bit of research which we did in 2014 and published in the Leukemia Lymphoma. The basic purpose of the study was to correlate plasma levels of Imatinib and correlate them with molecular responses. We did see that a level above 1 produced more responses. And more important for today's talk is that we found that in patients who were given Gleevec versus who were given standard Indian Imatinib, there was no difference in the Imatinib trough levels. So there is ample evidence. In addition to my study, there are at least 5 or 6 other studies from India and the rest of the world which confirm that quality generic Imatinib is as good as the innovator. Ladies and gentlemen, it is also important to realize that this is a study from Sweden, that life expectancy of patients with chronic myeloid leukemia today, with the availability of tyrosine kinase inhibitors, approaches the life expectancy of patients in the general population. And just to show you this details of this study published in the JCO, whether you have a male patient of 55 years or a female patient, this is the life expectancy, the dotted blue line of patients in the general population, and this is the life expectancy of patients with chronic myeloid leukemia. And since 2010, this has come together. And the same holds true for females. The same holds true for patients who are 65 years of age. The same holds true for patients who are 75 years of age. And also the same holds true for patients who are 85 years of age. So the mortality now in patients of chronic myeloid leukemia is not happening because of CML, but it is happening because of the comorbidities which they have. And it has also been seen that relative survival with TKI by response to therapy, the more and the deeper response you have, and that is directly related to your 5-year survival. And if you have a good cytogenetic response, a deep molecular response, or a complete molecular response, then your 5-year survival is in excess of 95%. So sometimes it becomes critical to switch therapies. And to discuss these time points, I'd like to invite my friend and colleague, the next speaker in our series, Dr. Jeff Lifton.
Well, thank you very much for the opportunity to do this. I'd like to thank the organizers and my colleagues for joining. My name is Jeff Lipton. I'm a medical oncologist at the Princess Margaret Cancer Center in Toronto, professor of medicine, University of Toronto. And my practice is half CML and half allogeneic stem cell transplant. I'm going to look at changing therapy and some issues regarding toxicity. So let's start with some cases. First case, 54-year-old man with a 3-month history of early satiety and weight loss of approximately 12% body weight. Spleen is enlarged at 14 centimeters, and blood work showed a white count of 123 with a standard left shift. And the workup showed chronic phase CML, Philadelphia chromosome positive, BCR-ABL positive, and he's an intermediate grade by so-called LTS. No significant comorbidities. Originally, he was debulked with hydroxyurea and allopurinol, and dasatinib was chosen as a second-generation drug for first-line treatment. At 3 months, had a 6% BCR-ABL level response, so this is classically less than the 10% that is thought to be a good response at 3 months. By 6 months to 0.4% by the international standard, and by 12 months, 0.05%. At 14 months, he presented with dyspnea orthopnea and was found to have a pleural effusion. And this is not an uncommon finding with dasatinib, with up to 1/3 of patients developing this at one time or another. Remember, this is something that occurs as an autoimmune response. It is not a cardiac failure response. So chest x-ray revealed the pleural effusion, so the dasatinib was held, and he was treated with a combination of diuretics, furosemide and spironolactone, and the infusion was gone by 3 weeks. Dasatinib was restarted at a lower dose of 70 milligrams. And we do know that the chances of pleural effusions do go down as the dose is reduced, but if a person has a pleural effusion, then they have about a 1 in 3 chance of getting it a second time, and again, 1 in 3 of getting it a third time. So even at the lower dose, he sustained his PCR level at 0.01% or 4 logs. And the pleural effusion, however, recurred at 22 months. Again, the dasatinib was held, treated again with diuretics, disappeared in 4 weeks. Dasatinib was reduced again to 50 milligrams daily, but the effusion occurred 2 months later. So that dasatinib was stopped, and again, the effusion was treated completely and disappeared. So we've now gone through several dose reductions with the dasatinib. Despite this, we have problems with the recurrent effusions. So what are the options for treatment in this patient? Well, switch to another second-generation drug, nilotinib, at 300 milligrams twice daily. Switch back to a first-generation drug, Imatinib, at 400 milligrams daily. When we think about switching, we never think about going second-generation to first, but it is a possibility. Or switch to another second-generation drug, bosutinib, at 400 milligrams daily. Or are all of these options? And I think the answer to this is the fact all 3 of those, in fact, were options that could be used. Elected, however, to go with bosutinib at 400 milligrams daily. Now, what are the things you need to consider in this patient given the past history, both previous to treatment and the treatment history during dasatinib treatment? Now, we do know that patients may get some diarrhea initially with bosutinib, which usually resolves within a few days. Hypertension, which is found to be a long-term side effect, needs to be watched for in bosutinib. Recurrent pleural effusions. Or is 2 and 3 of these an issue, or 1 and 2 of these an issue? Well, usually persistent diarrhea doesn't occur after those first few days or weeks. And in fact, there's some suggestion even that by grading up the dose over a few days or weeks, you might not get much diarrhea at all. Hypertension still needs to be looked at. And there's now a little bit of literature out there in a few patients that patients with a previous history of pleural effusions with dasatinib may in fact get pleural effusions as well with bosutinib, which is as well a SRC inhibitor. So these are things that need to be kept in mind down the line. But otherwise, the choice is good, and the patient would do well on this particular treatment. Second case. This is a 24-year-old man with a 2-week history of fatigue and a 15% body weight loss over the previous 3 months, and again associated with early satiety. So as you would expect, the spleen is palpable at 22 centimeters below the costal margin. You know, when the spleen is this big, you don't need an ultrasound to measure it. White count was very high at 286, classical left shift, high platelet count, which you do find as well, bit of anemia. The bone marrow is compatible with chronic phase CML blasts for 2%, standard Philadelphia chromosome, BCR-ABL positive, high so-called score in this case. So initially, while we're trying to figure out what this patient has to be sure, debulking the patient with allopurinol hydroxyurea, cytogenetics or the molecular comeback showing it is CML. And in this case, generic imatinib was started at 400 milligrams daily. Now, some people will argue, should you start a second generation drug when you have high so-called risk? Perhaps there is an advantage over hydroxyurea in the randomized studies, but over imatinib in the randomized studies, but imatinib is not a wrong choice. And because of coverage, this person only could start on imatinib. When the white count was down below 25, this is when it starts. Starting imatinib at a higher dose often takes longer to capture. And the hydroxyurea and allopurinol will eventually stop. At 3 months, he no longer had a palpable spleen and was in hematologic remission. At a 0.7 log reduction, or international standard of 18%. Now, some people might say this is a failure because it didn't hit the 10%. The only reason this is brought out here is there's now something called halving time, which has been used both by the Australian and the German group. But in order to do an appropriate halving time, you have to know what the patient's percentage is at diagnosis, not the laboratory percentage, which is the usual comparator in most patients. So he had less than an ideal percent if you went by the laboratory percentage. In this case, a halving time, because this patient's initial percentage was something like 250% of the laboratory, is actually a reasonably good response. But the imatinib was increased to 600 milligrams because halving time was not standard. At 6 months, the log response was a little better, down to 7.2%. Imatinib was continued. At 9 months, not much of an improvement. And again, by 12 months, we're now up to where we have the equivalent of roughly a complete cytogenetic remission. By 15 months, response seems to be waning. So the log response was reduced. And the first rule of thumb is when you see this, repeat it, because sometimes there can be a laboratory error. So what do you do now? Well, talk to the patient. Make sure there's been no other changes in the patient's health or other medications that may compromise the use of your TKI. Look to see if this patient is having side effects from the treatment, which may have an impact on their willingness to take the drug or their compliance. If none of these are true, just check if they're compliant. Unfortunately, younger individuals are less likely to take the drug, will miss doses. And we do know from some of the studies from the Hammersmith Hospital a few years ago that the importance of compliance, missing more than 2 or more doses a month, is very significant in the response. If none of these are true, repeat the bone marrow cytogenetics to look for clonal progression, because this may be a sign that the patient's accelerating on treatment. And also do kinase mutation testing, looking for a mutation that may confer imatinib resistance. So break down the workup and start with the simplest things. Are you sure about the quality of the generic? This person was on a generic. Well, in where I am, we have good generics, but not every country has all the generics of top quality. Some are excellent, some are very poor. Is this patient having any side effects? Is, for instance, they're having a lot of GI side effects because it's imatinib, and this causes problems when he wants to go out and do things every morning? Is the patient taking other medications? As these may be prescription, over-the-counter, naturopathic, recreational, all of which may affect the absorption or the activity of the drug. And are there social issues? Can the patient pay for the drug? Or are they skipping doses because they don't have the drug all the time? Is the drug not available all the time because he's maybe dealing with a pharmacy that doesn't get it to him on time? Does he have psychological or social issues about just wanting to be treated? And these are not things you should ignore. If none of these are the case, repeat the bone marrow cytogenetics and do kinase mutation testing by Sanger, which most of us have available, or by NGS. So if adverse events are affecting the compliance, then you must deal with the adverse effects to improve the compliance. So maybe it's the schedule which he takes the Imatinib. Maybe he hasn't been taking it on a full stomach and is having GI side effects. Maybe he's taking it at bedtime and lying down afterwards. Try introducing some co-medications that may help with the side effects. So maybe a bit of a Lomotil or something else may help with diarrhea. Or if none of those work, you may need to consider switching to a different TKI with a different side effect profile. If there's evidence of disease progression by acceleration, either morphologically or by cytogenetics, this is an issue where allogeneic transplant becomes really important. There's some literature that says if someone's in an accelerated phase of diagnosis, they may do very well with the TKI. But if they've progressed while on treatment, that is not a good prognostic feature. And these are individuals, particularly young individuals, like they should be considered for an allograft if it's an option. An option being, is there a donor available? Is it an individual in a country or a place where allogeneic transplants can be done? Can someone pay for the transplant? All big issues, and these vary from place to place. If the CML still is in chronic phase with standard Philadelphia chromosome, but now you have a mutation, switch that inpatient to a second or third generation TKI that would be active against that mutation. So it is a logical process, but you need to consider everything and don't come to conclusions early. So what are some of the summaries? Well, even with the best drug and compliance, we know directly 25% of newly diagnosed patients will only achieve a TFR. And this means that roughly 75% will be on indefinite or even lifelong therapy. And therefore, we have to deal with the side effects that potentially will come along down the line. And as an earlier slide that was presented by Hemant showing that even if you don't get TFR, even if you don't get CMR, even if you don't get 4 log reduction, just achieving a 2 or 3 log reduction in transcripts, these individuals will do extremely well, and their overall survival approaches age-matched control, as the Swedish study showed. So let's look at adverse events. This is something that needs to be done by both the physician and the patient. So you need to communicate. So the patient has to tell you, but you have to ask the patient. And make sure the patient doesn't have perceptions about what's going on, or you have perceptions about the patient. Believe the patient. And because we may be dealing with lifelong considerations in terms of treatment, and some of these toxicities are cumulative over a lifetime. So let's look at some of the side effects. Well, this is what I pointed out earlier, and this is from a recent review that we published, looking at 100% of patients. Remember, only about 25% achieve TFR, even if everybody wants to attempt this. So again, we're looking at 75% of patients are on drug. So although it's a noble goal for most patients, it is not a reality for the majority of patients. So we really need to prevent disease progression and deal with the side effects. Now, this is from a review that was written a number of years ago, and I think still is a beautiful review. It's from Elias Jabbour, who's at MD Anderson. And compliance is really multifactorial. The patient has their own responsibility. We as treating physicians have responsibility. And there's some treatment responsibility related to the drug itself. And we need to consider all these individuals. It comes together in this Venn diagram to yield non-adherence in some patients. And non-adherence results in bad outcomes. So we need to look into all these things in order to be sure about the adherence. Side effects are not unique to any one drug. Again, as this Venn diagram shows, is They may be more common with one drug than another, but they're not unique. For instance, everybody associates pleural effusions with dasatinib, but they could occur with any of the other TKIs as well. So just because you have a side effect that you don't think is associated with the drug you're using doesn't necessarily mean it's not due to the drug. Consider that always. So let's pay attention to the long-term side effects. Here are just a few examples of things that are showing up. Arterial obstructive events with nilotinib, renal dysfunction long-term with imatinib, pulmonary arterial hypertension is a long-term side effect with dasatinib, bosutinib-induced hypertension, vascular events with ponatinib, and even the new drug that will soon be getting approval in many countries may have some arterial obstructive events, as the recent randomized study against bosutinib demonstrated, that there were there even more so than in the bosutinib arm. So we'll now go to take-home messages, and I want to hand this back to my colleagues.
Very interesting. And now we're going to talk about the important conclusions and the take-home messages. The life expectancy of the CML chronic phase patients, approaching that of age, sex, match, person, without CML, only if expert management provided the patient. This is that we must follow our patients with experts to obtain these important survival conclusions, this important life expectancy. For the newly diagnosed patients of CML, we all know, we have shared several options available, and with the availability of the generic dasatinib and bosutinib, second generation TKI in first line and also in second line, within reach of many patients. So we have today a lot of possibilities of treatment. TFR, treatment-free remission, is a reality today and should be the goal of treatment for at least a population of patients and a group of patients as young patients and also female patients that are desirous of having a child, if not all the patients. Also, the choice of the TKI for the newly diagnosed patients will depend obviously on the cost, the comorbidities, and the convenience and toxicity.
So to continue the summary and conclusions for our CML webinar and our take-home messages, the prevalence of CML is expected to increase hugely. This is a disease in which very few patients are dying, and that pool of patients of CML, is increasing. And even in the most developed countries, and certainly in the developing countries, we need to gear up to take care of this large number of patients. And we need to make sure that these patients do not have any long-term toxicities. We need to assess them for treatment-free remissions. So we really need to gear up our infrastructure. Then we need guidelines and consensus statements for treatment of CML patients, particularly in the low and middle income countries where the problems which we've already highlighted to you. And we also need free or subsidized access to second and third generation TKIs or their generic versions, which I'm happy to tell you is slowly happening in the emerging economies. We need to make sure that for the small number of patients who are candidates for allogeneic stem cell transplantation, the availability and the access is there. And we need to make sure that the testing to monitor the TKIs becomes more prevalent, becomes more in tune with the recommended guidelines, and subsidies provided to patients to get this done. We have the Max Foundation model in several developing countries in which the drug is provided free and coupons are provided for subsidized TKI testing.
We need to look at innovative strategies for molecular testing, point of care testing, taking the mountain to Mohammed, which is a great illusion in this case. We need to standardize molecular labs. There's still a lot of labs which are not standardized, and doing comparisons may be very difficult. We really, with some of the new machines and kits that are available, what can be done in India can also be done in Canada or Argentina. whether we need combinations of other drugs with TKIs to try and get more people to deeper responses and treatment-free remission remains to be seen, but that is, I think, part of the future. And I think we need CML centers of excellence in many countries. So these would be reference centers, reliable centers where physicians in smaller centers can ask questions, send their patients, send their results in order to maintain the best of results or get the best testing done. And we need studies in a lot of countries, not just in the Western world, but a lot of countries, in order to try and see the practicality of using drugs and doing things in the real world. And with that, I'd like to conclude and turn it back to Carolina.
Thank you very much for this excellent webinar with very important and real life subjects. So we thank Total Health, and I thank also Jeff and Hemant, and we are seeing in another webinar. Thank you very much.